Great. Thank you for inviting me today. I'll just get started. So today I'll be talking about MACPAC experience analyzing Medicaid and CHIP data with a focus on the statistics on Medicaid spending that we include in our MACSATS data book. I'll discuss the two primary data sources for Medicaid spending, the adjustments we make to estimate spending at the beneficiary level, and some examples of these analyses from our data book. MACPAC is a nonpartisan federal commission that provides evidence-based analyses and recommendations to Congress, the Department of Health and Human Services, and states on Medicaid and CHIP. We have 17 commissioners appointed by the Government Accountability Office, and we meet publicly several times in the spring and fall. We release 2 reports to Congress each year in March and June, and we publish other informational sources such as data books and issue briefs. Today, I'll be discussing the data analyses included in MACSATS, our annual data book on Medicaid and CHIP. The MACSATS data book compiles a broad range of Medicaid and CHIP statistics into a single publication released each year in December. The purpose is to bring together in one place federal and state data on these programs that come from multiple data sources and are often difficult to find. The data book provides context for understanding these programs and how they fit into the larger healthcare system in terms of federal and state budgets, enrollment and spending, and beneficiary health and access to care. The entire data book is available on our website, and each individual exhibit from the most recent year is also available as an Excel spreadsheet on the individual exhibit landing page. I'm going to focus primarily on MACPAC's work to provide state-level data on Medicaid spending. There are 2 primary sources of data on Medicaid spending at the federal level: the CMS 64 Financial Management Report and Transformed Medicaid Statistical Information System, or TMSIS. The CMS 64 is a report of the state's actual expenditures on benefits and program administration and is used to determine the amount of federal match received. Because of this tie to federal match and the regularity of reporting, the CMS 64 data is considered to be the most timely and reliable source of data on aggregate Medicaid spending. TMSIS is not directly tied to federal funds and is more of a research-oriented data set. States report detailed eligibility and claims data to CMS through TMSIS. It is the only federal Medicaid data source for information on eligibility, demographics, service use, and spending at the person level. The next few slides provide examples of the spending analyses we have produced using these 2 data sets. This exhibit uses CMS 64 data to show total Medicaid benefit spending by state and categories of service. A few things I'll highlight in this example. The first is that managed care spending represents the capitation payments the states made to managed care plans. The CMS 64 does not collect information on what the plans actually paid to providers. The second is to highlight the negative $136 million in managed care spending in Connecticut. While the CMS 64 is an accurate accounting of expenditures within the year, it sometimes appears to show anomalous amounts of spending for a specific state, service, or population. This is because the net expenditure report includes spending on services paid during the reporting quarter, as well as prior period adjustments, which are increases or decreases made to expenditures previously reported. These adjustments result from regular business processes such as overpayment recoupments, or other activities such as corrections that reclassify spending into the appropriate services or populations. In certain cases, these prior period adjustments can create anomalies in a single year of data and can create large swings in year-to-year trends presented in the CMS 64 data for a particular state. This exhibit from our MACSATS data book shows fee-for-service spending for hospitals with a breakout of different types of supplemental payments using CMS 64 data. As you can see from this table, supplemental payments make up over half of fee-for-service payments to hospitals. These data demonstrate how important these supplemental payments can be to understanding total spending on hospital services. MACPAC is one of the few organizations publishing TMSIS data on a regular basis. I just wanted to point out a few methodological choices we make to account for data anomalies or other spending that may not be recorded in TMSIS data. MACPAC makes some adjustments to the amounts reported in the TMSIS to match what is reported on the CMS 64. These adjustments to TMSIS data are meant to provide a more complete estimate of Medicaid benefit spending across states that can be analyzed by eligibility group or other enrollee characteristics. We adjust TMSIS amounts for several reasons. TMSIS generally understates total Medicaid benefit spending because it does not have data on disproportionate share hospital payments. and additional types of supplemental payments made to hospitals and other providers, doesn't have Medicare premium payments, and certain other amounts. TMSIS generally overstates net spending on prescribed drugs because it does not have data on rebates from drug manufacturers. Although TMSIS does allow states to report supplemental payments and drug rebate collections, most states are not reporting these data at this time. The extent to which spending in TMSIS differs from that reported on the CMS 64 varies by state, meaning that a cross-state comparison of unadjusted TMSIS amounts may not reflect true differences in benefit spending. The methodology MACPAC uses involves the following steps. We aggregate the service types into broad categories that are comparable between the two sources. This is necessary because there's not a one-to-one correspondence of service types in TMSIS and CMS 64 data. Although TMSIS does include a new variable that corresponds to the service categories reported on the CMS 64, many states are not currently submitting complete information under this variable. We calculate state-specific adjustment factors for each of the broad service categories by dividing CMS 64 benefit spending by TMSIS spending. We then multiply the TMSIS dollar amounts in each service category by the state-specific factors. For example, in a state with a fee-for-service hospital factor of 1.2, each Medicaid enrollee with hospital spending in TMSIS would have that spending amount multiplied by 1.2. Doing so makes the sum of the adjusted hospital spending amounts among individual Medicaid enrollees in TMSIS total the aggregate hospital spending reported by states on the CMS 64. One thing to note is we don't include DISH payments and certain other supplemental payments made under 1115 waiver authority, such as uncompensated care pools or delivery system reform incentive payments, DSRIP, when making the adjustments for hospital spending. We don't include that spending because the dollars could be used more than just Medicaid enrollees, such as care for the uninsured or investments in infrastructure. Other organizations such as KFF and CMS frequently use similar methodologies to merge data from both sources, although they may use a different methodology. For example, they may use proportions of spending across eligibility groups in TMSIS to allocate CMS 64 spending to these groups. There will likely be some differences between what MACPAC reports and what other organizations report due to these differences in methodologies. And just a reminder, all of this description on our methodology can be found in the technical appendix in MACStats. So just wanted to show a couple more examples of the analysis we've done with TMSIS data. This exhibit in our data book shows Medicaid benefit spending per full-year equivalent enrollee, or FYE, by eligibility group and service category. This graphic is at the national level and is designed to help visualize and compare the spending per FYE across the different eligibility groups in each of the large service groupings that we use. And this table shows spending per enrollee by state and eligibility group and is useful for comparisons across states. It also shows the spending for all enrollees and for full benefit enrollees. I'll wrap up this presentation with just a few things to keep in mind if you're analyzing these data or using the information produced from these data. The first is to think about the strengths and weaknesses of the data source. As I mentioned before, the CMS 64 is considered to be the most complete source and contains all Medicaid spending, but it is at the aggregate level, whereas TMSIS can provide information at the beneficiary level and can allow for more granular analyses on very specific services, but it may not contain all spending, such as supplemental payments or drug rebates. Because of these pros and cons, it is also important to think about the methodology when designing analysis or seeking out that information on the methodology when using analyses from organizations such as MACPAC or KFF. For example, the way MACPAC makes its adjustments to gross up TMSIS spending to match the CMS 64 relies on state averages and is more reliable when using large categories of service and beneficiary characteristics. However, if you're doing an analysis on a more specific population, such as children in the welfare system, or specific service such as behavioral health drugs, the spending and utilization patterns may differ significantly from the state averages. And it may be more appropriate just to use the amounts reported in TMSIS and not make that adjustment to the CMS 64. For example, generic drugs receive a lower rebate than brand drugs. So if you're looking at a class of drugs where most are generic versions, then applying the average rebate of over 50% would actually understate the net spending for those drugs. It is important for researchers and analysts to provide information on the adjustments and the assumptions made in this analysis. And likewise, it is important for users of those data to read the methodology in the footnotes to understand what's included in the data and how to interpret the results. And with that, I'll end my presentation. Thank you.